Hi, my name is Jennifer Jones, and I'm going to talk to you today about stroke, mainly stroke protocol and the most recent evidence-based practice on how to treat patients that present in the hospital with signs and symptoms of acute ischemic stroke. Prior to watching the presentation, I'm asking that everybody fills out the pre-course assessment just so that we kind of get a baseline of your knowledge regarding stroke protocols. So to begin with stroke, some facts. Stroke is the fifth leading cause of death amongst Americans. Its mortality rate has decreased in recent years. Most of this is due to recent protocols that allow us to catch stroke symptoms early so that we can start treatment as early as possible. It is still estimated that 795,000 Americans suffer from a stroke annually, and this costs the U.S. approximately $33 billion a year. The associated healthcare costs not only have to do with treating the acute ischemic stroke, but it also has to do with the long-term disabilities that are associated with stroke victims. It is the leading cause of serious long-term disabilities. Stroke reduces mobility in more than half of stroke survivors age 65 and over. Early detection of stroke leads to the most positive patient outcomes, and thrombolysis using IV TPA is one of the few evidence-based acute stroke treatments. Now we're going to go on to some evidence-based practice recommendations. Through my research, I found out that it is recommended that alteplase, which also known as TPA, is recommended for treating acute ischemic stroke in adults only if symptoms of the stroke started, usually in less than 3 hours, so 3 hours from the onset of symptoms. There are some cases where they will treat up to 4.5 hours from the onset of symptoms. There are certain other criteria that needs to be met. First, we do have to rule out whether or not it is a hemorrhagic stroke, and we do this by a CT scan. The administration of the TPA has to be within the 3 to 4.5 hour mark after the onset of symptoms. Otherwise, past that mark, it is no longer effective and it is not a treatment of choice. From that point on, they're usually just going to manage the symptoms and the disabilities associated with the stroke. It was shown, research has shown that administration of alteplase between 0 and 4.5 hours after onset of stroke symptoms was effective treatment for acute ischemic stroke because it decreased the probability of death or dependence, and treatment of acute ischemic stroke with alteplase between 0 and 4.5 hours from onset of symptoms was a cost-effective use of national health services. So now we're going to go over our inclusion criteria. I did give you a handout. This includes the inclusion and the exclusion criteria. So inclusion criteria would be somebody that presents with acute ischemic stroke causing major deficits. So somebody that is noticeably having a stroke. The onset of symptoms needs to be less than 3 hours before treatment begins, but again, there are some very few cases where they will consider doing TPA up to 4.5 hours after onset of symptoms. And then the patient has to be greater than or equal to 18 years old. So they will not treat children with TPA. Now the exclusion criteria, there's quite a bit more exclusion criteria for the administration of TPA than there is inclusion criteria. It is a very dangerous medication, so care has to be taken in how we administer it. If there is any significant head trauma or a prior stroke in the previous 3 months, they are not a candidate for TPA administration. If they have any symptoms that suggest that they may have a hemorrhage at all, of course, if they're bleeding in their brain, we do not want to make the bleeding worse by giving them TPA. An arterial puncture in the previous 7 days, history of an intracranial hemorrhage, intracranial neoplasm or aneurysm. More exclusion criteria would be any recent intracranial or intraspinal surgery, elevated blood pressure, and this is a systolic blood pressure that is greater than 185, any acute internal bleeding, any acute bleeding diathesis. This is like if somebody has any conditions that makes them bleed easier. Blood glucose level that is less than 50, or if the CT demonstrates a multilobar infarction. So as you can see, in regards to inclusion-exclusion criteria, there is much more exclusion criteria. The exclusion criteria predominantly has to do with bleeding, though. If there's any signs of bleeding, we do not want to administer TPA because we do run the risk of causing death. Actually, it's somebody dying because they will bleed out because, as we know, TPA is a very strong medication and it is going to cause the patient to bleed. Target Stroke is an initiative that has been enacted recently, and this is hospitals in order for hospitals to get accreditation with Target Stroke, they have to follow this specific protocol. And this protocol, it's the Target Stroke Protocol, which is recommended by the American Stroke Association. It is based upon the most recent evidence-based practice and for TPA administration. So there are several steps. I also gave you a handout regarding Target Stroke and all the steps and what it all entails. So pretty much we'll go through steps. The very first one, this on the PowerPoints is just a brief summary, but the handout is a little bit more detailed, so if you want to follow through and read the handout. First, EMS pre-notification is the first step, and this is going to be if EMS, when they are receiving a patient or picking up a patient, and they do believe that the patient is suffering from acute ischemic stroke, they are going to contact the hospital and let the receiving hospital know as soon as possible that they do believe this person is having a stroke. This is going to reduce the door-to-needle time. Hospital is going to have stroke tools. This is going to be a toolkit. It's a rapid triage protocol, clinical decision support, stroke-specific order sets, guidelines, hospital-specific algorithms. Pretty much it's going to be a power plan in the hospital that it's going to be initiated if a patient presents with acute ischemic stroke. There's going to be a rapid triage protocol. So immediately when a person is brought into the emergency room, or if they're already a patient on the floor in the hospital and stroke is suspected, there is going to be a protocol that's enacted which is going to set off a list of procedures and things that need to be done so that if they are a candidate for TPA, it can be administered as quickly as possible. So when they do present to the emergency room, they are going to be assessed immediately. If they are assessed and they are evaluated and it does come up positive that they are having an acute ischemic stroke, there is going to be a stroke team notification. Once the stroke team notification is sent out, that is going to be phlebotomy is going to be notified, lab's going to be notified, CT is going to be notified. All of the areas of the hospital that would play a part in determining what type of stroke this patient is having, they're all going to be notified immediately so that everything can be done as quickly as possible. First thing is going to be a CT scan of the head. A CT scan of the brain is going to show us if the patient is bleeding. We want to make sure that they don't have a brain bleed or that they're hemorrhaging because we do not want to give them TPA if that's the case. The patient should be taken to CT within 25 minutes of arrival. Within that time as well, labs should be drawn. The pertinent labs are going to include PT and INR. Again, this is going to show their likelihood of bleeding. It's also going to include Chem 7 CBC. This should be done within 30 minutes of arrival. As soon as you realize this patient is a possible candidate for TPA, the alteplase should be mixed. And then administration of TPA should take place as soon as the inclusion-exclusion criteria have been considered. And if they have decided that this person is a candidate, then you need to rapidly administer the TPA. once a patient is begins receiving the TPA, they are immediately transferred to ICU. They need one-on-one care while they're receiving TPA, so they will be in ICU during the administration. If given a patient that does not meet the criteria for TPA, they may go to a vascular surgeon if they want to consider removing the clot, if they think that's a possibility of doing something like that. Otherwise, they're probably going to be transferred to another unit in the hospital, and they're going to manage the symptoms associated with a stroke as opposed to actually trying to reduce the symptoms of the stroke itself. So all of this should take place from the arrival to the emergency room to the time of the first bolus of TPA should be given in less than or equal to 60 minutes or 1 hour. So while stroke remains the 5th leading cause of death amongst Americans, timely diagnosis and treatment can lead to more positive patient outcomes, thereby decreasing healthcare costs. The current evidence-based practice recommends administration of Alteplase within 3 hours, and in some cases up to 4.5 hours from onset of stroke symptoms. Hospitals are encouraged to follow the target stroke protocol, which recommends a door-to-needle time of less than 60 minutes. So now I have a link on here that I would like everybody to check out, and this is going to be how to give a proper MEND exam. MEND exam is it's a neurological exam. It's going to give us an indication if somebody is having an acute ischemic stroke. So it's something that's easy to forget when you haven't done it for so long. If you do it in nursing school and then you kind of forget about it, but it is something that is invaluable when we are evaluating patients that have possibly had an ischemic stroke. So check out this link, see how to do a proper MEND exam, everything that it entails, and then following this, I have a post-evaluation that I would like everybody to fill out, and please give me your feedback and be honest and let me know if there's anything else I can do to improve. So thank you so much for your time, and have a great day.